Welcome colleagues, members and friends. Welcome everyone to the FIP Virtual Congress and our event, Driving AMR Action in the New Decade. As with all the work across our federation, we do this in partnership, and I'm so delighted to say that we're working in close collaboration with GRIP, the Global Respiratory Infection Partnership. As you will all know, FIP is a global federation with more than 150 member organisations and science member organisations across the 6 WHO regions of our world. We represent more than 4 million pharmacists, pharmaceutical scientists and pharmacy educators. And all of us know, never more than during 2020, that AMR is a global challenge. Next slide, please. So, in our exciting programme for this morning, I will be offering some welcomes and introductions and some closing remarks, and we have Sabir Esak here and Phil Howard. Before we start, could I just ask you all to mute your phones? We will be capturing all of your questions in the Q&A box. Of course, you can use the chat box as well, but the Q&A box will provide us with a record of your questions throughout all of this, and the team will be trying to answer as we go. Next slide, please. So as I mentioned, globally, AMR is a growing challenge for us all. And for many years, it has been a priority area for FIP. In September 2017, the FIP Council approved the FIP Statement of Policy on the Control of Antimicrobial Resistance, or AMR. This statement sets out pharmaceutical policy recommendations for governments, pharmacy practice recommendations for personnel in the profession, and commits FIP to advocacy and facilitator, both at policy and practice levels, and to support our member organisations and to act globally. Next slide, please. The FIP Development Goals project is a major global development for our profession. This builds on the innovation that produced the FIP Pharmaceutical Workforce Development Goals, which were launched late in 2016 in the Nanjing conference. In turn, the PWDGs were inspired and adapted from the concepts that underpinned the United Nations Sustainable Development Goals. So the FIP Development Goals form the foundation for systematic action to support national and to meet regional and global healthcare needs. They will be launched on the 21st of September during World Pharmacy Week and will set the tone for the whole of that week's events. The FIP Development Goals project, it's actually a fabulous way in which we can unite around the next 10 years and seek to achieve change. FIP Development Goal number 17 is antimicrobial stewardship. We understand other prevention agendas are super important, but we wanted to make a statement globally about how important this is to our profession. The goal will look at strategic and systems and put them in place to develop a global workforce to deliver quality services for antimicrobial stewardship, practice to deliver policy on the ground, and effective change. And actually, they will put services and infrastructure in place to ensure that all of the profession can support the antimicrobial stewardship agenda within which lies antimicrobial resistance. Now, as I say, they will be launched on Monday, the 21st of September, and you are all welcome to attend the event. Next slide, please. Goal number 17, antimicrobial stewardship, comprises 3 elements. The workforce development element enables strategies and systems to be put in place to develop our workforce to deliver quality services for AMS. The practice element will ensure infrastructures and frameworks are in place to deliver services for AMS. And the science element will support and promote research and development of new antimicrobials, new antimicrobial combinations, and new techniques to evaluate the impact of antimicrobial stewardship programs. We've seen how science can champion endeavour during the COVID-19 pandemic. Next slide, please. I would like to now introduce the President of FIP, as Dominique Jourdain will introduce some words for us.
Dear FIP members, fellow pharmacists, colleagues, ladies and gentlemen, antimicrobial resistance, AMR, is a major public health concern with profound impacts on global, regional, and national healthcare and economies. In times when we are witnessing the huge impact of a communicable virus on our lives, it is more important than ever to act on AMR. We are in the midst of one public health emergency, but with the emergence of untreatable drug-resistant infections and diseases, we may soon find ourselves in another public health emergency. This ongoing coronavirus pandemic is presenting threats that are aggravating antimicrobial resistance. For instance, the World Health Organization, WHO, has warned that many individuals presenting with mild disease without pneumonia are receiving antibiotics, exacerbating the risk of AMR. In addition, hospital admissions increase the risk of healthcare-associated infections and the transmission of multi-drug resistant organisms, which in turn lead to increased antimicrobial use. Another potential threat, according to the WHO, is the wide use as disinfectants, because low-level exposure to biocidal agents can enhance the risk of cross-resistance to antibiotics. There is significant variation of global patterns of AMR, and the trends are continuously evolving. We must therefore evolve and adapt, and we pharmacists must increasingly lead and participate in local, national, and global activities. FIP recognizes the need for urgent attention and action. FIP took leadership in combating AMR with its first statement on AMR in 2008, but the problem of AMR has become more prevalent, and new recommendations have been issued by scientific and healthcare communities. In 2015, FIP published the reference document Fighting Antimicrobial Resistance, the Contribution of Pharmacists, presenting a comprehensive overview of pharmacist activities from all over the world. This document also set out a number of solutions, ranging from giving advice on influenza immunization, thereby avoiding subsequent bacterial superinfections, and responsible prescribing of trimethoprim by pharmacists to treat urinary tract infections, to stewardship programs to optimize antibiotic prescribing in hospitals, and the collection of leftover antibiotics. It is crucial that such solutions are reflected in all national AMR policies. In 2017, the FIP Council approved the FIP Statement on Policy on the Control of AMR. This statement set out pharmaceutical policy recommendations for governments and pharmacy practice, and made clear FIP's commitment to playing an advocacy and facilitator role at both policy and practice levels. In addition, FIP has contributed to the work of the WHO on AMR. FIP was one of the reviewers of the first interprofessional competency framework on AMR control that was published by the WHO in 2018. FIP also contributed to the WHO Health Workers Education and Training on Antimicrobial Resistance Curricula Guide. Both documents help to improve awareness and understanding of AMR through effective communication, education, and training. Our ultimate aim is to ensure that all health workers are equipped with the required competencies at pre-service education and in-service training levels to address AMR in policy and practice settings. FIP continues to support national pharmacy organizations in facilitating the essential contribution of pharmacies to AMR action plans around the world, which includes surveillance and monitoring and antimicrobial use and resistance, antibiotics distribution and regulation. This year, in partnership with the Global Respiratory Infection Partnership and in conjunction with RB, we are proudly driving a coordinated approach to action, culminating in the development of a FIP Pharmacy AMR Roadmap that we are launching today. This roadmap will be a compass to guide actions globally, sustaining momentum and tracking and evaluating progress on this global health priority for pharmacy. The AMR Roadmap will be a dynamic and interactive tool that will entrench pharmacy's leadership role in mitigating AMR. We commit to revisiting the progress on the AMR Roadmap implementation annually, culminating in a presentation of the FIP World Congress in 2023, where a special Health Ministers Summit will be held. In conclusion, the fight against AMR and support of rational antibiotic use requires the action and collaboration of all stakeholders, industry partners, governments, health authorities, healthcare professionals and patients, and continued global discussion on how to achieve progress, followed by action and implementation. We would like to thank all our partners from GRIP and RB, and also our fellow regional champions pharmacists who are passionately driving forward action with us. FIP and pharmacists globally are committed to being the part of the solution. Long live pharmacy, long live FIP.
So, good morning, everyone. Distinguished guests, colleagues, ladies and gentlemen. I'm really privileged to share this platform with Dr. Catherine Duggan and Professor Philip Howard. The Global Respiratory Infection Partnership is honored to partner with the International Pharmacy Federation to drive AMR action in a new decade by pharmacy. These are my disclosures. I'm chairperson of the Global Respiratory Infection Partnership, as well as the member of the Global Hygiene Council, both of which are sponsored by Reckitt and Benckiser. This workshop is a partnership between GRIP and FIP, sponsored by an unrestricted educational grant from Reckitt and Benckiser. The objective is to come together as a global community of pharmacists to pledge commitment to action in AMR. The session will begin with a brief overview of the partners and their work in mitigating antimicrobial resistance and advancing antimicrobial stewardship. Catherine has given us an excellent overview of what FIP is doing and intends to do going forward. We will then unpack the pharmacist's role in 3 of the 5 strategic objectives of the Global Action Plan on AMR, using the established behavior change model that encompasses capability, opportunity, and motivation. We will end with information on the follow-up regional workshops and how the outputs of these workshops align with FIP's developmental goal on antimicrobial stewardship. So let's start with a little bit about GRIP. GRIP was founded in 2012 and is made up of 12 members from across the globe. Our very first declaration was that we, the Global Respiratory Infection Partnership, recognizing the imminent onset of the post-antibiotic era and taking full cognizance of the declining numbers of new antibiotics in development, hereby commit to 3 things. Firstly, consistent, sustainable, evidence-based advocacy and intervention for rational antibiotic use and antimicrobial stewardship. Secondly, formulating a framework for non-antibiotic treatment options for respiratory tract infections, such as sore throat, common colds, influenza, and cough. And we focused on upper respiratory tract infections because these are amongst the infections where inappropriate antimicrobial use is most rife. And finally, facilitating multi-stakeholder commitment to antibiotic stewardship and rational antibiotic use. GRIP focuses on reducing antimicrobial use and resistance to maintain the efficacy of antimicrobial treatments for current and future public health. GRIP's seminal work has been in its 5P pentagonal framework for policy and behavioral change amongst prescribers, pharmacists, and patients to prevent antibiotic resistance, as I mentioned, using acute respiratory tract infections as an archetype. The framework focuses on antibiotic stewardship and conservation through coordinated, multi-pronged, multi-stakeholder, multidisciplinary partnerships that are underpinned by national and global policies and create a consistent global approach to AMR. The framework adopts a patient-centered symptomatic management strategy. It offers practical advice to primary healthcare teams, and it facilitates change towards prudent use of antibiotics. And I encourage you to look at the GRIP website on all of the resources and materials that we have for patients, prescribers, policymakers, and pharmacists. I will discuss the 5P framework in greater detail later in this presentation. Some of the guiding principles for the 5P framework and the associated activities include to identify patient attitudes towards upper respiratory tract infections, limit antibiotic use to high-risk patients with proven bacterial infections, to establish a local policy for symptomatic relief of upper respiratory tract infections, educate healthcare professionals on the appropriate treatment, and support healthcare professionals to enhance communication skills. So these are all of the activities that GRIP's a repository of resources for healthcare professionals. So let us focus on antimicrobial resistance. Antimicrobial resistance, or AMR, is a problem that threatens the sustainability of an effective public health and medical response to infectious diseases across the globe. It is estimated that currently 700,000 people die annually from drug-resistant infections. This will become progressively worse unless we adapt the way we develop and use antibiotics. And may I say here that we are already using antibiotics inappropriately in the COVID pandemic. The consequences of AMR at the patient level include prolonged duration of illness, greater risk of infection, transmission, increased morbidity and mortality rates, and substantial financial and societal costs. This map is from the O'Neill review on AMR and shows us that 10 million deaths will be attributable to AMR by 2050 if we don't act immediately and urgently. It also highlights the fact that the low and middle income countries will be disproportionately affected by AMR. The public health impact is far worse. 28 million people will be poverty stricken. There will be a 7.5% decline in global livestock production, a 3.8% decline in global export, and a cost of $1 trillion in additional healthcare costs. I think all of you are aware that every one of these predicted scenarios on the impact of antimicrobial resistance will be and is actually being worsened by COVID-19, because the pandemic has engendered the inappropriate and excessive use of antimicrobials. Despite the lack of evidence to support their use, there are several reports of antiretrovirals, antimalarials, and antibiotics that are currently being used in the management of COVID-19. Such inappropriate use is increasing selection pressure and escalating antimicrobial resistance. The World Health Organization endorsed the Global Action Plan on Antimicrobial Resistance, which outlines 5 strategic objectives for addressing AMR. The GAP was endorsed by the United Nations General Assembly and the World Health Assembly, where all member states agreed to develop national action plans on AMR based on the 5 strategic objectives of the Global Action Plan. To briefly go through these, the first is to improve awareness and understanding of AMR through risk communication and education. The second is to strengthen knowledge through surveillance and research by undertaking national AMR surveillance, improving laboratory capacities, and undertaking research and development. Excuse me. The third strategic objective deals with reducing the incidence of infection through effective hygiene and infection prevention and control, both in healthcare communities as well as in healthcare facilities as well as in communities. The fourth strategic objective speaks to optimizing the use of antimicrobial medicines in human and animal health, and it speaks to access to quality antimicrobial medicines, regulation, and antimicrobial stewardship, as well as reducing the availability of antimicrobials without prescription. And finally, it speaks to ensuring sustainable investment through research and development by measuring the burden of AMR, assessing investment needs, and establishing procedures for participation. Just a reminder that FIP's revised statement of policy on the control of AMR further supports the WHO Global Action Plan and its 5 strategic objectives. Of the 5 strategic objectives, the 3 that resonate most with the policy and practice roles of the pharmacists are strategic objectives 1, 3, and 4. The first speaks to improving awareness and understanding of AMR through effective communication, education, and training. The third, to reduce the incidence of infection through effective sanitation, hygiene, and infection prevention measures. And the fourth, to optimize the use of antimicrobial medicines with the focus on stewardship. So I want to go through the pharmacist leadership role in each one of these strategic objectives. You may find greater detail in the preparatory video that we made where I speak to the leadership role on all of the 5 strategic objectives and specifically how the COVID-19 pandemic has made this more urgent and more important and has really highlighted the role of the pharmacist in mitigating AMR going forward. So let's start with our leadership role in education and awareness. And here I want to draw on the pentagonal framework of the Global Respiratory Infection Partnership. As mentioned earlier, this framework speaks to the role of policy, prescribers, pharmacists, and patients on the prevention of antimicrobial resistance. So it speaks to policy to advance antibiotic stewardship and conservation and encourage symptomatic management. It speaks to patient empowerment on self-management. It gives pharmacy guidance in the provision of advice to patients. It gives prescriber guidance on antibiotic stewardship and effective dialogue with patients. And its aim is the prevention of resistance by the rational use of antibiotics. And with absolutely no bias, I want to say that pharmacists are the kingpins or pivotal in this framework because pharmacists validate prescribing practice and thus have tacit oversight of prescribers. They are strategically placed to educate patients and affect behavior change in terms of patient demand for antibiotics. They are critical to the implementation of policy as well as the generation of evidence to inform policy-related interventions, and they prevent antibiotic resistance by impacting on prescribing practice, patient behavior, and policy implementation. What about our leadership role in hygiene and IPC? Pharmacists can prevent or reduce the incidence and transmission of infections in communities by facilitating vaccination campaigns and promoting hygiene, sanitation, and hand washing. Vaccination prevents infection, it eliminates the need for antimicrobials, and thereby reduces the subsequent selection pressure associated with antimicrobial use. In terms of COVID-19, WHO guidance includes hand washing, avoiding personal contact, and using masks. Never has personal and targeted home hygiene and the use of personal protective equipment been more important than during this pandemic. Our leadership role in healthcare settings is for us to participate in the IPC committee, ensure availability of cleaning agents and PPE for patient and personnel safety, establish pharmacy quality control programs to prevent contamination of pharmaceutical products, especially sterile products, encourage the use of single-dose packages of sterile products, and recommend proper labeling, dating, and storage of sterile products. WHO guidelines on PPE are as follows. Firstly, perform hand hygiene, put on the gown, put on the mask, put on eyewear, and finally put on the gloves. And we are all aware of PPE shortages being reported from both high and low middle income countries during the COVID-19 pandemic. So what is our leadership role in optimal antimicrobial use? In this context, I want to highlight the role of the pharmacist at national policy level as well as local practice level. At the national policy level, we must practice rational medicines use, defined as patients receiving the appropriate medicines in doses that meet their own individual requirements for an adequate period of time and at the lowest cost both to them and the community. We should participate in drug regulatory bodies to ensure the safety, efficacy, and quality of medicines. We should implement the AWARE categorization in the essential medicines list, and I'll speak a little bit about this in a while. We also have a very strong responsibility to optimize supply chain management, ensure that there's always access of the correct first-line antimicrobials and that there are no stockouts. And finally, we have a very strong role in identifying substandard and falsified medicines. I want to give a little bit more on the AWARE categorization. This is new, it's in the newest essential medicines list of the WHO, and it speaks to antibiotics in 3 categories. The first is the access group of antibiotics, with activity against a wide range of common susceptible pathogens with lower resistance potential than antibiotics in the other groups. These are the first-line essential antibiotics that should be widely available, affordable, and quality assured. The watch group of antibiotics encompasses antibiotic classes that have higher resistance potential and/or antibiotics that are at relatively high risk of the selection of bacterial resistance. And these include most of the highest priority antibiotics listed in the critically important antimicrobials for human medicines. So these are the ones that we should watch for escalation of resistance in. And finally, we have the reserve group of antibiotics that should be reserved for the treatment of confirmed or suspected multi-drug resistant organisms. These antibiotics are usually treated as last resort options. Just want to highlight the fact that COVID-19 has interrupted supply chains by the closure of borders and travel restrictions and made room for substandard and falsified drugs to proliferate. At the practice level, we have an antimicrobial stewardship role. Antimicrobial stewardship promotes the safe, rational, correct, and effective use of antimicrobial agents to promote positive patient outcomes, rapid recovery from illness or infection, prevent or contain antimicrobial resistance, and reduce healthcare costs. Pharmacy can also play a role in promoting evidence-based symptomatic relief alternatives to antibiotics. Antimicrobial stewardship has been described as the 4 R's, where the right antibiotic is administered at the right dose, at the right time, for the right duration, obviously to the right patient. So I have extended these 4 R's to the 8 D's, and let us go through each one of these. The first D is diagnosis, is to ensure a non-viral etiology, that is, ensure that the infection is bacterial or fungal and not viral. Rapid diagnostics tests play a vital role here, and I can't emphasize the importance of etiology during the COVID-19 pandemic. We then have the drug choice. Here we choose the antimicrobial that is indicated with the correct spectrum of activity, opting for narrow spectrum in the first instance. We deal a lot with dosage forms. Choose the dosage form that best suits the patient and the infection. So for example, if we want immediate effect, we would go for IV. And if it's a pediatric patient versus an adult patient, we have options between suspensions, tablets, and injections. The next D is dose. Ensure that the dose will result in concentrations above the minimum inhibitory concentration at the site of infection, taking into account pharmacokinetics and pharmacodynamics. So the concentration at the site of infection must be high enough to kill off all of the bacteria and not select for resistance. The next D is the dosing interval. Again, in keeping with PK/PD, dosing intervals should ensure that the antimicrobial concentrations remain above the MIC to prevent the emergence of resistance from sub-inhibitory concentrations of the antimicrobial at the site of infection. The duration debate is still rife. This brings in the hit them hard and fast, short duration, high dose therapy versus the longer duration of conventional therapy. The conventional therapy is thought to exert greater selection pressure for the evolution of resistance, but the jury is still out on this. We then speak about disposable, and I speak here about expired drugs and not incomplete courses, to ensure that the correct disposal such that antibiotics do not contaminate water and sanitation systems. And the final D, and I suppose is a rather important one, is communication between the prescriber and the pharmacist, as well as the pharmacist and the patient, which is critical for the optimal and appropriate use of antimicrobials. So the leadership role, in summary, speaks to improving awareness and understanding, reducing the incidence of infection through prevention control, and optimizing the responsible use of antimicrobials. And we are focused on these because these will be the key focus areas for our roadmap going forward. It now gives me pleasure to hand over to my colleague, Professor Philip Howard, who will take us through the behavior change models in addressing AMR. I'm going to stop sharing my screen and ask Professor Howard to share his. Thank you very much for your time.
Good morning, everybody. My name's Philip Howard, and my only disclosures that I've got is that I'm the president of the British Society of Antimicrobial Chemotherapy. I'm also a visiting professor at Leeds University and consultant pharmacist at the Leeds teaching hospitals. So I'd like to talk to you about behaviour change in AMR. So community pharmacists are on the front line of primary care, and as such have a key role in conserving antibiotics, preventing their misuse, and instilling the concept of stewardship in the minds of both prescribers and patients. To reduce inappropriate antibiotic use in these areas, we must translate FIP's statement of policy and the WHO strategic objectives into action. To do so, behaviour change must occur by harnessing the interaction between capability and opportunity into motivation. The COM-B model of behaviour change developed by Susan Mitchie and colleagues is used widely. The behaviour change wheel on the left illustrates how we can increase the motivation to make these changes. Pharmacists have the physical and psychological capability to address AMR because we have the knowledge, skills and abilities, or the proficiencies acquired via education and practice. We also have the physical and social opportunity to achieve this by delivering their country commitment to the UN Political Declaration and the Pharmacy Association's commitment to the FIP policy statement on AMR, which then motivates them to prevent, contain and mitigate AMR and eliminate it as a public health threat, thus delivering behaviour change. I'd like to demonstrate how we could achieve these changes through examples that demonstrate the COM-B approach in education, policy and public health. This cycle on the right shows that a patient visits his family doctor or other healthcare professional expecting antibiotics and puts pressure on them to prescribe or supply them. The patient is prescribed antibiotics, often inappropriately, as seen in this European research on the left, where there are much higher rates of prescribing as seen to the ideal. Now, this reinforces the patient expectation that antibiotics cause their infection to improve, even if they didn't at all. An education of patients at first contact by pharmacists is key to break the cycle of expectation of antibiotics. This intervention of training community pharmacy teams to use patient education leaflets to educate patients about common respiratory conditions led to a reduction in referrals to family doctors by between 46 to 82% for different upper respiratory tract infections compared to the control group who provided normal verbal advice only. There was no impact on sore throat, which I will discuss later. The Public Health England Primary Care Unit have developed and evaluated a range of patient information leaflets for respiratory and urinary tract infections. They are available in 24 languages and pictorial versions for those who cannot read. It can be obtained from the link below. They explain how long symptoms usually last for different types of infections and what patients can do to look after themselves. There is a section on safety netting to help the patient or carer know what to do if they get worse and to recognise the signs of sepsis. And also at the bottom of each of these is some information about antibiotic resistance. The final example of education is from South Africa. This study trained hospital pharmacists in antimicrobial stewardship to work alongside doctors and nurses to help improve antibiotic use. The pharmacists focused on 4 areas: getting blood cultures done before starting antibiotics, and there is good evidence to show positivity rates fall from 31% when blood cultures are taken before the first dose of antibiotic, down to 19%, if taken within the first 90 minutes after antibiotics. Also, targeting antibiotic courses are longer than 7 or 14 days, and patients on more than 4 antibiotics at the same time, and also those with antibiotic combinations with duplicate coverage. And the results that you can see on the top right-hand side show a remarkable 18% reduction in antimicrobial use and improvements in taking blood cultures and shorter durations. So an excellent model to copy. So how can we educate pharmacy teams around stewardship? Interactive e-learning using a blend of techniques allows people to learn at their own pace rather than having to attend training days. And certainly with COVID at the moment, face-to-face learning is becoming more and more challenging. This slide shows a range of free courses that the British Society of Antimicrobial Chemotherapy has developed to educate healthcare professionals on stewardship. There have been over 200,000 learners in almost every country in the world. There is a general course in 6 different languages supported by an e-book on antimicrobial stewardship. There is a range of bespoke courses on sector-specific stewardship, such as primary care or veterinary practice, or to advanced stewardship, such as antifungal stewardship and resistant gram-negative infections. There are also region-specific courses that take into account the local culture, and you see examples of Africa and the Middle East and North Africa. And these courses have been evaluated and appear to be very effective from what you can see at the bottom. So if we look at an example of policy, then effective guidelines provide an opportunity to decrease antimicrobial resistance. Good guidelines should tell you when an antibiotic is not needed. And community pharmacy should use guidelines like these to know when to refer to a prescriber or when to offer self-care and safety netting advice. Where clinical scoring tools are recommended, we as pharmacists should also use them. The example here on the screen is from the UK National Institute of Clinical Excellence, showing acute sore throat. It recommends using a clinical scoring system, either fever pain or Centaur, to decide if antibiotics are required for a possible streptococcal throat infection. And these guidelines are available for most of the common infections, and the new ones are being sort of developed every month. And so if you don't have good guidelines in your own country that tell you when or when not to use antibiotics, have a look at some of these. This slide builds on the sore throat assessment and shows that there are many different guidelines available for sore throat, and all use either clinical scoring systems, and many use point of care tests for streptococcal A antigen testing. Now, the lack of availability of testing in countries that recommend these might be a barrier for community pharmacy to reduce inappropriate antibiotic use in some countries. So an example of public health is around appropriate disposal of unwanted antibiotics. There is good evidence that many patients stop taking their antibiotics when they feel better or when they wish to drink alcohol. They will often keep these antibiotics for the next time they feel ill, or they will share them with their friends or family, or even give them to their pets instead of going to the vet. If they do destroy them, they are often flushed down the toilet, and that can cause antimicrobial resistance within the environment. So this example here is from New Zealand of an antibiotic amnesty about educating the patients to return unwanted antibiotics to the pharmacy for destruction. And there will also be an opportunity to reduce inappropriate use by doing so. The second example of public health comes from England. They have used a simple message of antibiotics don't work for everything over the last 3 years. The simple message is a song repeated regularly on television and radio and backed up through posters and information leaflets. When this has actually been evaluated, it's shown that the impact was 78% of the public would not ask their GP for antibiotics, and 93% of family doctors said it would help them to say no to antibiotic requests. So it's all about keeping antibiotics working. The other element about keeping antibiotics working in England was around the use of a checklist for when pharmacists dispense a prescription for antibiotics. This example here builds on the work of the Royal Pharmaceutical Society. The checklist allows the pharmacy team to ask the patient what the antibiotics are for and whether they have any allergies. If they are pregnant, have problems with their kidneys or liver, and if they have had any recent courses of antibiotics. The checklist also asks, but it's not shown on this slide, what knowledge the patient already has, so the pharmacist can target advice, including appropriate antimicrobial information and leaflet for the particular infection. As part of this research, an educational webinar to give pharmacy staff the capability and motivation to provide self-care and adherence to advise patients, carers collecting antibiotics. The example shows how a patient collecting the antibiotic for a UTI would have usually just had it dispensed and could possibly develop an upper UTI infection. But by using the checklist, the pharmacist contacts the family doctor to discuss whether the infection might be resistant, as they did not respond to the first course. The outcome was a change of antibiotic and the patient got better. So this is an example how antimicrobial stewardship can occur in the community pharmacy. Hopefully these examples of the COM-B behavioural change model in practice has been useful. And I will now hand over to Catherine Duggan to introduce the AMR Commission and Roadmap.
Thank you so much, Phil. If you pop on the next slide, please. Perfect. Thank you, Phil, so much. So, colleagues, with everything that you've heard from both Sabia and Phil around the initiatives in different countries and across different organisations to manage the 5 Ps, it's really important that FIP manages this globally. So we all realise the importance of AMR and the fact that it is even more critical in the year 2020 with COVID-19 hitting us all. But it's now time to build on the great work that we've heard today and to act. And we wish to announce to you all that we are planning a FIP AMR Commission and a roadmap for implementation. Next slide, please. So I just want to spend a moment to walk you through the purpose of the Commission. You'll all remember at the start of the presentation, I mentioned that our federation seeks to work in partnership and in collaboration, and today's a really good example of how we do that. But the Commission will adopt an inclusive approach to antimicrobials and their management, and will firstly identify the work streams across research, pharmacy practice and education, using lots of the examples that you've heard today to map existing AMR specific and AMR sensitive initiatives to identify and address the gaps. Secondly, the Commission will define a pharmacy relevant research agenda to mitigate AMR. Thirdly, there will be mapping and developing of focus education and training. And this is actually some of the examples that Phil gave us about how we share education and practice and professional development opportunities across pharmacy. Then we will develop pharmacy advocacy, policy and practice toolkits so that countries and practitioners on the ground can use them. We wish this commission to be very high level, and it has actually been supported by the FIP Bureau, and the Bureau seeks that the commission itself will be responsible for implementing the FIP policy statement with support from our member organisations, a huge advance. The commission will ensure the relevance and adaptability of all activities and interventions, and this commission will launch during World Pharmacy Week. I mentioned at the start of my contribution today that World Pharmacy Week starts with the launch of the FIP development goals on Monday the 21st, and the launch of the AMR Commission, together with highlighting how the AMS development goal will be enacted, will take place on the 24th of September. And we really urge you all to attend. Next slide, please. I mentioned at the start that we have 3 elements to the FIP development goal on antimicrobial stewardship: 1 on workforce, 1 on science, and 1 on practice. Dividing them into 3 is only that we can give them focus. We're not saying that one is more important than another. And in addition, you will all see that these map to the 5 Ps that Sabia announced earlier on: policy, patient, pharmacy, prevention, and prescriber. And it's really important that we ensure these goals link to existing work, build on existing work, and that we then set out a roadmap for how we would implement these globally, nationally, and regionally. I'm going to hand over now to Sabiha. Sabiha, tell us some more about that roadmap.
Thank you, Catherine. The roadmap is going to be the first deliverable of the AMR Commission, and this will be at regional level as well as global level. During the regional workshops, key actions will be identified, solidifying regional commitments to entrenching pharmacy's role in AMR mitigation. A number of the attendees will have completed a survey that's giving us an idea of the types of initiatives that are needed from a pharmacy perspective nationally as well as regionally, and we hope to be able to collate all of these to identify the key priority areas for each region. The roadmap is designed to be an iterative tool that will act as a compass to guide actions globally, sustaining momentum and evaluating progress in pharmacy. It will be revised annually, culminating in a presentation at the FIP World Congress in 2023, where a special health ministers summit will be hosted. So I want to emphasize the fact that this is going to be a living document, and we will have the opportunity to revisit it at least annually to look at progress and determine whether certain initiatives need to be reprioritized. The next slide, please, Phil. We will use the COM-B model as a framework and translate it into action areas to focus on the roadmap. You will agree that we as pharmacists have enormous capability, opportunity, and motivation to mitigate AMR in our regions and globally. This is what we will populate this slide with as many initiatives as possible, both from the survey as well as during the workshops, which are going to be held on the 16th and 17th of September. And before I go on to the way forward, I would like to perhaps take a few questions and answers, questions that have been forwarded through to us via the chat and the QA panel. And Erin and Susanna have done a tremendous job of answering most of them. But Phil, I have 2 questions for you, and I have 2 that I will take on. So Phil, the 2 questions for you are: how can we link pharmacy with primary care GPs? That's the first question. And then the second question is, many times physicians start antibiotic therapy waiting for the culture and antibiogram. Is this a good strategy or a bad one? So while you think on that, let me answer the first question. The first question, and it's been asked repeatedly in the chat, is, do antimicrobials work on coronavirus? No, there is no therapy or treatment for coronavirus at the moment. There are no antiretrovirals, no antimalarials, and no antibiotics that are indicated for the coronavirus. There's lots of effort being placed on development of a vaccine, and there are a number of clinical trials underway, but the WHO has not endorsed, and neither have any of the international infectious diseases societies or communities endorsed any treatment for coronavirus. So unfortunately, for the moment, we do not have pharmaceutical treatment for the coronavirus. Phil, do you want to answer your 2 questions, and I'll get to my 3rd one?
Yes, thanks. So the first one was around working with family doctors. So one of the things that I would sort of recommend is as part of being a pharmacist in the community anyway, you should have a good working relationship with your local set of doctors. And most people, I think, already have them. And people realize that the pharmacist is a really useful information resource when they want to know various bits and pieces. So if you don't have that relationship already, I would say, see if you can make an appointment at a suitable time to actually meet your local family doctor practice, and see how you can actually get involved about the more appropriate use of antibiotics. The other bit is that often many family doctor practices are normally overworked, and they really struggle with seeing all the patients in a timely manner. And they're often really grateful for a community pharmacy who can actually take some of that burden off them by almost triaging patients and sending the ones who need to see a family doctor first, and providing self-care advice or products for those that don't. So I hope that helps. The second one was about the question about not starting antibiotics while doctors wait for results for cultures and sensitivities for samples they may have sent away. If an infection isn't serious, then actually this can be a really good strategy, because often in areas where there are very high levels of antimicrobial resistance, or the patient has had lots of infections before with different antibiotics, there is a chance that the normal sort of first choice empiric antibiotics might not work. So if you can actually get the results back to tell you which is the appropriate antibiotic, that can certainly help. The second bit is not all infections are bacterial. So COVID's a prime example at the moment, because what we're seeing is when patients have a sample for testing to see if the patient has COVID and it comes back as positive, the evidence base tells us that there are very few patients who also have a bacterial infection at the same time. And certainly evidence from the UK has shown it's less than 1%, but in the hospital, we're starting about at least half our patients on antibacterials who don't need it, which will probably drive resistance further.
Thank you, Phil. Catherine, we have one question for you. How does one get involved with the AMR Commission? I'm sorry, Phil, can I ask you to move, sorry, Catherine, before you answer, Phil, can I ask you to move the slide one up, please? Move to the next slide, thank you. I'm sorry, I didn't say next, no. To the table, please. I'm sorry. So I'm sorry, I didn't say next slide at this point, but this is the table that we're going to be populating at the regional workshops. And some of this will be populated from the results of the survey that has been undertaken, but also from the AMR facilitators that have been identified to lead these regional workshops next week. So Catherine, sorry, please go ahead. How does one get involved in the AMR Commission?
Well, we would urge colleagues to get involved in the regional events on the 16th and 17th, because there's several practical things that we need to do ahead of the launch of the Commission. What we are doing at FIP is launching the goal and the intent to populate the Commission with colleagues from across the regions and from across different areas of practice based on the roadmap that comes out of those events. So it will be inclusive. It will be based on the person's contribution to practice, whether that be workforce science or the practice elements, patient-facing roles, and we will seek to be as inclusive as possible. What I do know, Sabiha, is that we will never have space for everybody who will be interested. So I imagine the Commission will seek to fill the Commission with the appropriate number that is workable and doable. And then we would seek to have regional working groups and reference groups. So there is a place for everybody, and the Commission itself will be based on the criteria that we set. But I would urge everybody to come on the 16th and 17th, because that's the way that you can start to direct the work in your region and then influence FIP to support that. Sabiha, I have got one clarification that came through on my messages around WHO endorsed treatments. Now, Sabiha was mentioning whether there were any antivirals or antimicrobials for the use for the treatment of COVID-19, and there aren't. But of course, we know that WHO has endorsed the use of dexamethasone in severely ill patients as an anti-inflammatory. So that was just to clarify to colleagues on the line that it's the therapeutic antiviral or antimicrobials for COVID that there is no endorsed treatment around. Thank you. Thank you, Sabiha, for letting me speak.
Thank you very much, Catherine. And yes, dexamethasone is being advocated for, especially ventilator COVID-19, serious COVID-19 patients on ventilator therapy. So thank you for that, and thank you for that clarification. I've got a question here that speaks about how should pharmacy undergraduates play a role in AMR? And Zuzana has actually answered it very well, in that she said that there's a competency framework that has been developed by the World Health Organization, as well as an associated curriculum. And that is now being used by most pharmacy schools to incorporate into the curricula. But I would like to highlight here is every single one of us, pharmacy students, pharmacists, pharmacy assistants, can become AMR advocates. But to become an AMR advocate, we really need to make sure that we are speaking from a point of knowledge. We must have the most updated knowledge related to antimicrobial resistance and speak based on evidence. There's so many open courses on AMR, and Phil can give you a list of those that are available for free from the British Society of Antimicrobial Therapy. But also I would recommend that you subscribe to feeds such as the REACT, AMR Insights, CDEP and CIDRAP, and WHO Virtual Communities of Practice. The second important part in terms of the role you can play is learn how to communicate correctly. So the people that you will communicate with will be healthcare professionals, there'll be policymakers, there'll be other students, and there'll be people in the general population. They all have different health literacy levels. So you need to be able to get the message across correctly to the correct group by making sure that it is, people can align with it or can understand it. And then become members of professional networks, show your interest in the FIP AMR Commission. We'll probably be looking at stakeholder communities and look at different ways in which people can become involved. So the point of addressing students is to, right at a young age, inculcate an ethos of not overusing antimicrobials, and so to pass it on from generation to generation. So I think that students play a very important role in becoming AMR advocates. Okay, great. I've got a few more questions coming in.
Sabiha, just to jump in there and say that any of the issues coming out of the roadmap events and the AMR Commission, we will ensure that our Young Pharmacist group is engaged and ensure that the IPSF, the International Pharmaceutical Students Federation, is engaged as well. And colleagues can get engaged through those groups into AMR or specifically through the Commission. We'll have a little link as well. We're noting all of these concepts and ideas down. It's great.
Great. So I have one question, is do pharma companies producing antibiotics do any effective roles regarding AMR? And I can answer yes. I'd like to refer you to the antimicrobial resistance benchmark, where a number of pharmaceutical companies that are producing antimicrobials and antibiotics take part in ensuring access as well as stewardship initiatives. This is an annual publication by the Access for Medicines Foundation, and it shows year-on-year increase in the number of pharmaceutical companies involved, as well as how they improve their access and stewardship initiatives in all countries, including LMICs. There is also any new drug that becomes available as an antimicrobial has to incorporate access issues, so they are easily and equitably available across all income countries, but also stewardship activities also have to play a very important role in that. I'm looking at my chat to see whether I have any more questions. I don't. Okay, I've got one. Can you also address the special issue of topical antibiotics? I've got a request about topical antibiotics, and there's a systematic review on the use of topical antibiotics in sore throat or upper respiratory tract infections. This was a review done by a group of members, and there was not any evidence to show that they are beneficial, harmful, nor that they affect antimicrobial resistance. And that's because none of the studies actually looked into antimicrobial resistance at the time. I hope, John, that answers your question.
Could I add also onto that? So,
please go ahead.
So one of the common conditions that people often use topical antibiotics for is for impetigo, and we've certainly seen resistance there. And NICE, so the English Evidence-Based Medicine, have just produced a guideline around this, recommending hydrogen peroxide as the preferred choice with a really strong evidence-based for it. And that actually gets us away from using antibiotics by using antiseptics sort of on there, where we rarely see any resistance coming in. So I say there are some good options out there instead of using antibiotics topically.
And then Phil, maybe a last question for you, the role of point of care testing and the importance of point of care testing.
Yeah, so I've answered this one online while I've been listening to the talks. Point of care testing has some real opportunities over sending samples to the lab. If you work in a community, sometimes it can take 1 or 2 days before you get results back for a sort of a patient. The places where I think there's some real opportunity to use point of care testing, where there is a strong evidence base that it works, and we actually have the quality assurance in systems that it gives the expected results, is you could use them where in places whereby a doctor might often start an antibiotic whilst they're waiting for some results to come back from the pathology lab that may take 1 or 2 days. But if you have a result within 15, 20 minutes, you can actually sometimes avoid even starting the antibiotic to begin with. And I think there's some real opportunities for community pharmacy there. And certainly within England, we have been in University of Leeds, we've been exploring areas where the family doctor would say, start this antibiotic if the result comes back positive, and we'll get the community pharmacist to actually do the test and make that decision. So we're exploring that type of approach at the moment, and hopefully we'll see it routinely used in the future.
Thank you very much, Phil. If you'll just move on to the next slide, please. Great, so I just want to speak about the next steps. First of all, we want to encourage all 1.5 or 2 million, 1 to 2,000 of you that have been listening to this webinar to please sign up for your regional workshops. We want to publish this global roadmap and follow it up with educational needs survey to inform the types of activities that have to be done. And then Catherine has already spoken about the Pharmacy Week activities and launch of the FIP AMR Commission. So we urge all of you to register for these workshops scheduled for next week, 16th and 17th. The AMR Commission will be launched on the 24th of September at 1 p.m. Central European Time. And we really, I can't emphasize more that we need your voices in developing the regional and global pharmacy-specific roadmaps and action plans to mitigate AMR. I'm sorry, my messages are coming up as well. Let me just ask if... So there's a question about why, sorry, I'm taking the prerogative as group chair to ask one final question. the lack of consistent recognition of the symptomatic treatment alternatives. Why isn't there symptomatic relief given greater prominence? Does anybody want to take that? Phil, do you want to answer that type of question?
Yeah, I'm not quite sure I heard the question clearly there. Was there something about symptomatic treatments?
So why aren't symptomatic treatments more prominently appear in guidelines?
Yeah, so one of my roles in the UK is I actually sit on the NICE Managing Common Infections Guideline Committee, which is a standing committee we meet every month. One of the big problems that we have is often pharmaceutical manufacturers who target products to be sold in the over-the-counter care of patients don't do the appropriate clinical trials in place, comparing them to current best practice or placebo. And it's really important that if we want to see some of these symptomatic treatments used or included in guidelines, we get better quality evidence. And so what I would say to the manufacturers out there, engage very closely with some of your local universities and who can work with, help design the appropriate studies, and then especially the pharmacists, because they can then work closely with community pharmacists, and you can set these studies up. And we're starting to see more of these coming in. So I would say to those looking to produce some of these, whether it's new products or existing products, let's get a good evidence base out there. Let's use community pharmacy to do that research, and then we can actually see them included in some of the guidelines.
And just
Phil, can I add to that? Phil, could I just add to that and say that FIP could support that with perhaps data collection tools and with ways in which everybody could start to collect the same data so that we could start to compare and contrast. And then, of course, the tools that each country could develop could then be used to support other countries as well. And I think that kind of let's help each other along the way approach will be very, very effective in this endeavour.
Great. And just to say, African treatment guidelines for primary healthcare actually do advocate for symptomatic management, especially in upper respiratory tract infections. So go South Africa. Sorry, for next and last slide. So a webinar of such quality would not have been made possible unless there were some critical people. So I'd like to thank Dr. Catherine Duggan for advancing antimicrobial resistance and antimicrobial stewardship discourse within FIP, and for really getting the ball rolling on the AMR Commission as well as the AMS development goal. Adrian Shepherd for his visionary leadership of GRIP all the way back from 2012 to now. And then Jane, Erin, Ashlyn from Cello Health, and Carola and Susanna and Mila from FIP. Thank you for your invaluable support. We really appreciate all of your contributions to making today a success. And we look forward to seeing all of you on the 16th and 17th next week. Thank you very much for your time.
Thank you.
Thank you, Sabiha. Just to let you know, colleagues, we will gather all the questions and answers and provide that for everybody. Thank you.